Thank you, Dr. Lalit, Dr. Namrata, and Sipla for having me here. You have done a good cataract surgery, good rexus, clear cornea. Next day, patient comes with picture like this. You see a hypopyon, a good reaction in your eye. You are off what I have done wrong. Now, the first question comes in mind whether it's an infection or inflammation, because the treatment is diagonally opposite. If it is an inflammation like TAS, you need to load this patient with steroids. But if it is an infection, you need to load this patient with antibiotics. So that's the million-dollar question, and that's what I'll be talking about: post-operative reaction, infection versus inflammation. The problem is lab investigation like culture. It takes 48 hours, and only investigation that you can do immediately to confirm the diagnosis is gram staining and KOH smear, which is usually not available in our clinics. Decision has to be made clinically on your clinical acumen. We'll be covering our topic under these headings: history, symptoms, pain, vision, signs like chemosis, wound integrity, corneal haze, hypopyon, and fundal glow. If the patient has a pre-existing disease like uveitis and patient comes with inflammation, yes, it's most probably an inflammatory reaction, because we know after operating a uveitis patient, you will land up into inflammation the very next day. If the general condition is not good and patient gives an history of septic foci in the body like UTI or some infection in the wound, then usually it's infective. You also need to take in very good history from the surgeon whether a lot of manipulation was done or any kind of complication has occurred during surgery. And if these manipulation or complication has occurred, it's usually a sterile reaction. Endophthalmitis patient usually comes and tells you कि डॉक्टर साहब कल शाम तक तो ठीक दिख रहा था, रात को उठे तो सर में दर्द हो रहा था और मैंने एक आंख बंद करके देखी तो मेरी रोशनी खत्म हो गई. So this is a typical history what a patient of endophthalmitis gives. But this typical history never comes in all the patients. 70% patients will have pain, but rest 30% patient will not have pain. And if the patient gives an history of pain, then diagnosis of infection is made. If the vision is good, it's usually sterile, and if there is a sudden decrease in vision, it's infective and you need to inject this patient. If you have this angry looking eye with severe congestion, chemosis, then it's usually infection. Intraocular pressure is high in sterile inflammation and it's low in infective patients. Examine the wound very carefully. If you see a weak wound, a phaco burn, or you see this kind of inflammation or bleb-related infection, the diagnosis is clear that it's an infection and you need to give these patients with intravitreal antibiotics. Hypopyon, always whenever you see a hypopyon, it denotes that there is a severe infection in the eye, and you need to treat this patient. And if it is a dark brown hypopyon, then it's usually sterile. If it is yellowish or white in nature, which is increasing, then it's definitely infective. Pupillary dilatation is one of the very important points to diagnose whether it's an inflammation and infection. If the pupil is not dilating, then I ask my patient to sit in the OPD. I'll ask my attendant to put drops every 15 minutes. If the pupil dilates, then I'll examine the posterior segment and a lot of things become clear. But if it doesn't dilate, then I'll go in favor of infection. Fundal glow is the diagnostic criteria to differentiate between inflammation and infection. If you have a good glow, then it's usually sterile. But if you have a white or poor glow, then it's infective. And if you see exudates in the vitreous cavity, then it's definitely infective and you need not to wait in this patient. Go ahead and give intravitreal antibiotic. Many times, because the pupil is small, there is a lot of fibrinoid reaction. You are not able to see the posterior segment. Go ahead and do an ultrasound, and if you see a picture like this with a lot of exudates in the vitreous cavity, it's definitive infection, and intravitreal antibiotics should be given. Coming to TAS, presentation occurs within 12 to 24 hours. It is rapidly progressive. There is a limbal to limbal corneal edema, non-reactive dilated pupil. There is a severe AC reaction. Increased intraocular pressure is the hallmark of TAS. These corneal edema and increased intraocular pressure is hallmark of TAS, and if it occurs within 12 to 24 hours, then load this patient with steroid. But it's very important that you see this patient at least twice or thrice a day, or if you have an facility of admission, please do admit these patients. If you look into the etiology of TAS, there is no etiology. We talked cameral moxifloxacin can be one of the cause, viscoelastic reaction to abnormal solution, contamination of equipment with IOL, denaturated viscoelastic, residual detergents. All these factors can lead to toxic anterior segment syndromes. Consider TAS if not very severe presentation, and you start the patient on steroid, and if patient respond, then you confirm the diagnosis. We look at some of the examples here. This was a patient 2 days post-operative, 1 day post-operative. You can see a lot of fibrinoid reaction. The glow you can see is good. We started this patient on topical and systemic steroid. This fibrin reaction over a period of time decreased, and this patient improved to 6/6 vision. This is another patient. You can see the pupil is not dilating, hypopyon, no glow. We gave intravitreal Vanco with ceftazidime, and day 1 you can see the reaction has decreased. Day 5 we started this patient on systemic steroids, and you can see the hypopyon has disappeared, corneal edema has cleared, and day 10 the glow has come, and we started seeing the fundus, and this patient improved to 6/6 vision. Why I wanted to show this patient is this patient came 1 day post-op, had a finger count vision. Anterior segment was relatively quiet, but there was no glow. So I looked into the details, pre-operative details. Patient had 6/18 vision. So no glow. My diagnosis was spot on that it's an infection, it's not an inflammation. I didn't wasted any time on giving intravitreal antibiotic. And you can see just with intravitreal antibiotic, the patient returned to 6/6 vision within 15 days. This is one of the patient which didn't respond to intravitreal antibiotic, and this needed vitreous surgery with IOL explantation. And this is 4 weeks post-operatively, relatively clear cornea, posterior pole is good, silicone oil filled eye, and improved to 36 vision. This patient came to me with episodes of recurrent inflammation. Every 15 days that inflammation used to occur, and was given posterior subtenon tricot. And you can see here the eye, you can see whitish plaque here. This whitish plaque, if you have on the posterior pole with recurrent inflammation, you learn from the history of the disease, it's a P. acne endophthalmitis. It won't resolve by steroids. You need to do surgery in this patient. The surgery is remove the IOL and the bag, and this patient we did a removal of IOL with bag with vitreous surgery, and you can see this patient improved to 6/6. Once the eye was quiet for 6 months, I went ahead and did a glued scleral fixated IOL in this, and patient improved, is having 6/6 vision for almost 5 to 6 years. If you see this yellowish plaque over the retina, it's usually candida endophthalmitis, and these patients will require multiple intravitreal injections of antifungal agents and most probably surgery. Many a times, even with this terry-tail signs, we are not able to diagnose whether it's an infection or an inflammation. Then, in doubt, we usually give a therapeutic trial, start intensive treatment with steroid and antibiotic, do a close follow-up twice a day. If pure inflammation, it will start improving between 12 to 24 hours. If there is no improvement or worsening in the existing situation, err on the side of infection and do not delay in giving intravitreal antibiotics. This is a chart what I have made, which will guide you what has to be done. So if you have hypopyon, yes, it's infection. If it is whitish, then it is infective. If the glow is absent and if the exudates are there in the vitreous cavity, then it's the diagnostic sign to diagnose infection and do proceed in for intravitreal antibiotic. So the take-home message is sudden deterioration in vision, bad wound, pain, chemosis, hypopyon, poor glow with exudates in the vitreous cavity. It's an infective etiology. Go ahead and give intravitreal injections. If there is a pre-existing disease, surgical manipulations, complicated surgery, hypopyon, good glow, and eco-free vitreous cavity, it's usually sterile, and load this patient with steroids. After giving intravitreal antibiotic, we wait for 24 to 36 hours. If there is any worsening from the existing condition, go ahead and do a pars plana vitrectomy. If there is no worsening, we'll wait and continue on medical treatment. There is no significant improvement, then again we'll go for pars plana vitrectomy. And with improvement, if there is an improvement, we'll continue with the medical treatment. And I can tell you, in our center, we have been managing endophthalmitis, early diagnosis and treatment with intravitreal antibiotic. We are able to take care of 80% of the patients with endophthalmitis. Only 15 to 20% of the patients go ahead and get the vitreous surgery. So it's Dr. Lalit has also published an article, first treatment with an intravitreal antibiotic, at the first contact surgeon should give it. So it's very important to diagnose infection and inject at the proper time and then refer to the retina surgeon. To conclude, careful history from both patient and surgeon, along with close follow-up and timely intervention, can salvage most of the eye. Thank you very much for your kind attention.
Thanks, AG, for showing wonderful slides and a lot of take-home messages. Anybody wants to ask? You see, very nicely you said pure infection, no issue, give antibiotics. Pure inflammation, no issue, give steroids. But I think dilemma comes in a gray zone.
Yeah.
You mentioned gray zone. That is what bothers everybody. मैं ये करूँ या ये करूँ वाला. So that's usually situation like suppose a patient has corneal edema, faint glow, 6/24, 6/18 vision, but no vitreous exudates. So how do you approach?
So what I do, I'll make my patient sit there in the OPD, ask my attendant to put hourly drops and dilate the patient.
What drops?
Steroid and antibiotic, and plus mydriatics. And I'll ask him to give broad spectrum antibiotic covering gram-negative and gram-positive. And if the pupil dilates,
No, are you at this time thinking infection or thinking inflammation?
So that's a difficult. It will take me 12 hours to decide whether it's infection or inflammation. If the pupil dilates and if I can have a peep into the retinal vitreous cavity, yes, it's an inflammation. But if it doesn't dilate, I'll err on the side of infection.
So the message is, if you are not able to decide, ask the patient to hang around there, dilate this pupil very well, load this patient with maybe hourly or 2 hourly steroid drops, and see him again after a few hours before the end of the day. If you can see the retina very well, you can treat as inflammation. If something has gone slightly negative, give intravitreal antibiotic.
Yeah.
Is that correct?
And I give an example here. One of our colleague, a father had this kind of inflammation. He flew from Patna to get an intravitreal antibiotic. So the pupil was bound down. It was not dilating. I gave subconjunctival midricaine. That broke the synechia, and I could see the retina. Then I decided, yes, he has already got an intravitreal injection of tazobactam. I saw the vitreous cavity was pretty clear. I started that patient on steroids, topical and systemic, and that patient responded and is now 6'6" over a period of time.
So thanks, AG. I think these are sometimes tricky situations, but by the time we have umpty number of examples where the referring doctor has given intravitreal, all credit to him. I get the credit because I followed this patient, that's all, for 24 to 36 hours. Because whenever anybody refers a patient, I tell them to give an antibiotic, but do not expect instant response. It will take 24 to 36 hours for this. So thanks a lot, AG, for this very, very informative